A very good noon to all the ladies and gentlemen, esteemed guests, and distinguished speakers. Myself, Dr. Pallavi Chaugule, Associate Professor and HOD, Department of Rog Nidan Prakriti Vigyan, Manjushri Research Institute of Ayurved, Gandhinagar, currently working as Joint Secretary of Rog Nidan Vikruti Vigyan PG Association. Welcome you all to the 27th webinar on endocrinal disorders, clinical laboratory diagnosis and treatment. This webinar is conducted by Rog Nidan Vikruti Vigyan PG Association and is approved by Maharashtra Council of Indian Medicine, Mumbai. We are privileged today to have Dr. Ghansham Kodwani sir, famed professor and HOD, Department of Rog Nidan and at Government Ayurved College, Nagpur, as our today's chairperson. Sir has over 30 years of teaching experience and has credit of shaping lives of numerous PG students. I am delighted to see such a diverse and engaged audience gathered virtually for this important event. This webinar is not just a virtual gathering, it's a platform for insightful discussions, learning, and collaboration. Endocrinology, the study of hormones and endocrine system, aligns with Ayurveda's holistic approach to health and well-being. Ayurveda, an ancient Indian system of medicine, emphasizes balancing the body's doshas, dhatus. Ayurveda defines health as samadosha, samagnishta, samadhatu, malakriya, prasanna atma indriya, swastha itya bhidiyate. While endocrinology plays a crucial role in maintaining overall health and well-being, it encompasses hormonal regulation, metabolism management, reproductive health, development and growth, stress response, homeostasis maintenance. So overall endocrine functions are interconnected with the nervous and immune systems, highlighting the importance of holistic approach to health. So it is very essential to understand the intricacies of endocrinology and concerned advanced diagnostics and pharmaceutical interventions. To understand better the Ayurveda perspective of importance of harmony within the endocrine system for overall well-being. Integrating both approaches may provide a more comprehensive and personalized approach to managing endocrine disorders and promoting optimal health outcomes. Now, before we dive into our knowledge quest, I would like all our audience to be acquainted with our RVPJ Association. So, for the purpose, I invite Dr. Trupti Yavatkar Madam, working as Associate Professor in Department of Rog Nidan एवं Vikruti Vigyan at S.G. Mutha Aryangal Vaidyak Mahavidyalaya Satara, to do the honors. Please, ma'am, over to you, ma'am. Trupti, ma'am.
Yes, ma'am. Thank you. I'm audible, madam?
Yes, ma'am, you're audible.
Yes, okay. Good afternoon to everyone. I'm feeling very much proud to give the introduction of our organization. Our organization RVPGA, that is Rog Nidan Vikruti Vigyan PG Association, was formed in the year 2016 under the able and dynamic leadership of Dr. Subhash Wage sir, with the aim to give the legal status of pathologist and radiologist to the people of Rog Nidan. Our organization is duly registered under Societies Act of 1860 at Charity Commissioner Office, Nagpur. Postgraduate students, teachers of Rog Nidan and Vikruti Vigyan and Chaya Vikiran Vigyan can become our members. Ours is the only organization which is fighting for the lawful rights of Rog Nidan and Vikruti Vigyan PGs. Even the NCSM had also directed State of Maharashtra to consider RBPGA as stakeholder in the constitution of pathology regulatory body of the state. RVPG is pursuing this matter with state and central government. Not only this, RVPG is constantly pursuing the implementation of NCSM salary structure in all the private Ayurvedic colleges across the nation. All the communications and details are uploaded on our website www.rvpganagpur.com. Activities conducted by our organization are regular conduction of online webinars and offline seminars, both on national and international platform. So far now, we have conducted 27 national webinars on different diagnostic topics and a national conference on X-ray diagnosis held at Nagpur. Hands-on training program for PGs at our partner NABL Accredited Pathology Laboratory at Mumbai, Nagpur and Pune. We have planned a microbiological hands-on training program for our PGs on 9th March 2024 at Nagpur. Publication of various research papers of Nidan students and faculties in our peer-reviewed International Journal of Diagnostics and Research, IJDR, Interested can visit the journal site www.igdrindia.com. Our journal is enlisted in 8 databases. 2 issues have been published. Edited book volume series through our international publications RIPI, which is registered in Government of India's ISBN portal. Those who want to contribute book chapter can visit RIPI website www.rvpgaiip.com. We have published All India Rognidan PG thesis book consisting of all the Rognidan PG titles from 1985 to 2023 for easy reference of our PGs and all the faculties. We are giving legal fight for the issues of Rognidan and Vikruti Vidyan PGs at appropriate forums. We have our YouTube channel and Facebook page where you can see our educational activities past and live. Thank you so much for the organizing team for giving me the chance to introduce the great work of our organization. Thank you, madam, and thank you, Wage sir. Over to you, madam.
Thank you, madam, for introducing our association. Our today's distinguished speaker, Dr. Hari Mangtani sir, will delve into the complexities of endocrinal disorders today, sharing valuable insights and advancements in the field, from understanding hormonal imbalances to exploring innovative treatments. I would like to provide a brief introduction to today's speaker. Dr. Hari Mangtani sir is a renowned endocrinologist having well-flourished practice in Nagpur. Sir acquired his MBBS degree from NKP Salve Institute of Medical Science and Research Center, Nagpur in 1999 batch. Further, he pursued DCH degree at Wadia Children's Hospital, Mumbai, then continued his quest for knowledge by pursuing DNB Pediatrics at Jahangir Apollo Hospital in Pune. Sir has also earned experience as ICU registrar at Jaslok Hospital, Mumbai. Sir pursued his pediatric endocrine experience at Wadia Children's Hospital, Mumbai. Further, he completed his training and fellowship in pediatric endocrinology from Bharati Vidyapit in 2011-12. He also has teaching experience as lecturer in Bharati Vidyapit Medical College, Pune. Sir has completed his ICMR RCC in Medical Genetics and Genetic Counseling at the Department of Medical Genetics, SGP, GI, Lucknow in 2018. Further, Sir has earned fellowship in pediatric endocrinology at Alder Hey Children's Hospital, Liverpool, England, United Kingdom in 2009 and is awarded by the European Society of Pediatric Endocrinology. Sir, I welcome you, sir. Your vast experience, clinical experience, and subject expertise will deliver clarity to concepts and foster a deeper understanding of endocrinal health amongst our audience. We are honored to have you here, sir. Without further ado, I request you to enlighten us and begin today's knowledge session, sir.
Yeah. So thank you very much, Dr. Palli, for that elaborate introduction. And thank you, RVPG Association, for giving me this opportunity. So what I would like to tell you is that I am a pediatric endocrinologist. So I am specialized in looking after endocrine issues in pediatrics. Why pediatric endocrinology is an important thing, because as madam has said in the introduction that endocrine development or endocrine system, it deals with almost every part of the body, every organ of the body functioning from right from birth till the noon. So we'll look into a few cases. What I have done is I have designed a few cases to just give you a brief idea about how endocrine functioning in pediatric patients or in children helps us identify the problem earlier, and I'll also go through the different treatment protocols. But you must be aware of all the challenges which we face in pediatrics. So I'll be working on more. I am working on pediatrics, so I'll be presenting cases on pediatric cases. Now the cases will include the problems with puberty, problems with growth or height of the child, problems with bone growth, and obviously we'll be talking about thyroid and steroids and every other thing. So without wasting much time, I would like to start sharing my screen. I hope this screen is visible. and I am audible also. So, what is pediatric endocrinology? We'll understand from every case. We'll try to understand that what exactly is important in a child's endocrine system. So, coming to this case, I am audible now. Hello, can you confirm? The slides
Yes,
are
sir.
moving.
You are very much audible, loud and clear.
Okay, so this was 2.5-year-old male child who came with complaints of increased growth. Now, this is since 1 year of age, the parents have noticed that child was increasing in height and he's reaching his elder sibling. So, the elder sibling was 6-year-old, and the height of this 2.5-year-old child was equal to that. Along with that, the parents had suggested that he has increased appetite. He was aggressive, and he also get lower limb deformity. So we can see the bowing of the legs there and gait abnormality also. What additionally parents have noticed is the genital growth, and we can see the clinical picture that the genitalia has started growing and the child looks muscular. Uh, on examination, the child is tall for his age. Like 2.5-year-old child, we are expecting a height of around 90 centimeters, not more than that. Here, the child was 108 centimeters, so almost 20 centimeter taller than what is expected. Weight was also on the higher side, and there were signs of rickets. So there was bowing of tibia and pigeon chest present. Otherwise, there were no other signs. Per abdomen was also normal. There were no mass palpable, and there was generalized hyperpigmentation. So, if we see at the child, he had pigmentation. Once I look at the genitalia, uh, the stretch penile length. So, the penis size was 7 centimeter, which is expected when someone enters puberty. So, this genital were almost of 13 to 14 years of age, but the child is only 2.5 years. Scrotum is well developed, we can see, but testicles were small. When we palpated testes were down and they were small. And we cannot appreciate, I mean, if you can appreciate the pubic hair, they were shaven, but the child had pubic hairs, which is very abnormal thing to be there in 2.5-year-old child. So what is going wrong in this child? What we can understand or deduce that from somewhere male hormone testosterone is coming in this child, and this testosterone is causing all the changes in this child. Now, what are the sources of testosterone in a boy or is there are only two sources. One is testicle, and the other source of testosterone is adrenal gland. Here, when we see the testicle, they are small. So that gives you a clinical idea that the adrenal gland is now secreting extra testosterone, and we should start working on the laboratory. So first, after looking at the clinical picture and thorough examination, we should find out the or try to locate the pathology. So now, if we see this clinical signs and the symptom, this suggests a tall height, genital growth. So we know that this child is having exposure to testosterone. Now, from where the testosterone is coming is there are only two organ system. One is testis and the other is adrenal gland. Testes are small. So now we know that, okay, we have located the pathology towards adrenal gland, and that becomes a very clear cut case. Now, why the signs of rickets? Why this child has rickets? That also will come to know, because this child was growing fast, has become so tall, 20 centimeters higher, could not get enough vitamin D and calcium in his diet, and that's why he is developing signs of rickets. So, on examination, the bone age is advanced. There were signs of rickets and osteopenia. When we check the gonadotropin levels, both LH and FSH were on the lower side, and thyroid function test was normal. However, the testosterone was in a adolescent range, so late adolescent range, almost 13, 14 years of age. And when we did an ACTH was a higher side, that was 214 picogram per ml. So, if we are talking about endocrine tests also, these tests are very special tests, are to be done in a very specific lab where they have got machineries to at least preserve the sample till they are processed. That is very important. And 17 hydroxyprogesterone was on the higher side. This child had simple virilizing CAH. Now, what exactly CAH means is congenital adrenal hyperplasia. What happens here is the adrenal glands, it has got a function of secreting cortisol, and mineralocorticoid. Here, the cortisol is not getting produced, and that's why when the cortisol does not get produced, all the raw material or all the raw in the thing that because of the enzyme block, all the raw material get transferred to the next cycle, the zona reticularis, to produce testosterone. That's why the testosterone is high and the cortisol is low, and because of the negative feedback is low, the ACTH becomes high, and that's why, because when we see the formation of ACTH, there is a melanocyte stimulating hormone which gets produced simultaneously with ACTH, and thus these kids have hyperpigmentation. So what is the treatment for such kids is we have to start with steroid replacement. When we start with steroid replacement to this child, then the negative feedback starts working. The ACTH comes down, the hyperpigmentation resolves, and the adrenal gland, the overworking adrenal gland, it gets suppressed, and the testosterone level comes down. So this child was started on steroid replacement therapy and vitamin D and calcium supplements for rickets. So for steroid replacement became the definitive therapy. However, we fear using steroids, but here the treatment of choice is steroids, and vitamin D and calcium supplements for rickets were started in this child. So the take home message in this case, what I would like you to take is any secondary sexual characteristic which appear before 9 years in boys, they require endocrine evaluation. It is a natural process. I accept and I understand that it's a natural process, but the timing of this natural process is earlier. So we should consider any secondary sexual characters before the age of 9 as abnormal and requiring endocrine evaluation. Similarly, tall stature is not always reassuring. We have seen that this child was tall, but whether it was assuring for us, no, that was a part of pathology. Though the child was growing in height, that was a part of his pathology. Coming to this second case, similar, this was a 5-year-old female child, came with bony deformity and short stature. Now there were all the typical signs of rickets present in this child. Like you can see, there were rickety rosary, Harrison sulcus, there was wrist widening in this child, and tibial bowing. So you can see bowing of the tibia and all. Now, when we ask the history, the child has received multiple doses of vitamin D, 3 to 4 times she has received, and then labeled as vitamin D resistant rickets. So we all know that the commonest cause of rickets in India, at least, is vitamin D deficiency. Almost all over the world, also, if it is vitamin D deficiency, the first thing we have to rule out is vitamin D deficiency. Now, what has happened? The child has gone to different places, two, three doctors, and every time the first diagnosis made was vitamin D deficiency. Because the kids are poor, we tend to give them vitamin D directly without checking any blood test or without checking any other test, without doing any other test. So that's why the child received multiple doses of vitamin D, but her bone structure did not respond. So her bony deformities continue to increase, and that's why she was labeled as vitamin D resistant ricket very rightly. When I investigated, the calcium was 10, so adequate, and vitamin D was also adequate. The X-ray was reported as having healing rickets. So now, see, we are getting a report of an X-ray which suggested healing rickets. When I saw the X-ray, now if you closely observe the X-ray here, the shape of the metacarpals and shape of the bones, phalangeal bones, are not very classical or not very normal looking. They are abnormal looking metacarpals, and this child was having skeletal dysplasia. So any amount of vitamin D wouldn't have caused any benefit to the child. This requires more of an orthopedic intervention. Once the deformity is established, that has to be corrected surgically rather than, yes, vitamin D helps in preventing additional deformity developing in this child. But we cannot just keep on giving vitamin D as the child has received 3 to 4 doses. So what is the important take home message from this is we should always try to revisit in any condition, any adult, pediatric, gynec, anything, we should try to revisit the diagnosis if the response to therapy is not as expected. So everyone expected that this child to respond to vitamin D, and the child didn't respond, so we should revisit the diagnosis. We should try to think, are we dealing with something else? So that is true with all the scientific I mean, for all our society, that once we are treating something, we should not we should follow the expected path. We should be able to follow that on follow. If we are not getting, we should try to revisit or revise the diagnosis. So that is the take home message from this. Coming to another case, this was a 4-year-old female, came with swelling in the midline neck. This small swelling was size of a marble. Now, on examination, the swelling was moving with deglutition, but not with the protrusion of tongue. So very classical diagnosis of a thyroid swelling. So this was a thyroid swelling, but not a thyroglossal cyst, because on protrusion of tongue, the thyroglossal cyst moves. This was moving only with swallowing. So this was a thyroid swelling, and TSH was not very significantly high. It was 8.9. So whether it's a thyroid tissue, the sonography was done, and they suggested they could not see the thyroid tissue and no gland at the thyroid bed. So thyroid nuclear scan was done. Nuclear scan, fortunately, is done at Nagpur. So we did a nuclear scan, and it suggested that it is the only functional tissue. So only functional thyroid tissue present in the body was in the neck only, and you can see the uptake. And this was a ectopic or dysgenetic thyroid. So when it was not seen in the regular place, then it is a ectopic thyroid tissue. So the child was started on thyroxine replacement therapy, and this size gradually decreased. So important take home from this is not only lab test, we sometimes require special investigation to come or reach to a diagnosis, because we can see the lab here were not very useful. So sometimes we have to do special investigations like nuclear scan to come to a diagnosis. So we complete or a USG also done, was not showing anything significant in this child. No other investigation except for the nuclear scan. So that is the take home message from this case. Now coming to this case, this was a 4-month-old female child, came with this kind of a look. So we can see this more of a cretin-like face or hypothyroid face. The tongue is large, protruding, and the child is looking dull. The TSH was clearly high. There is no doubt in the diagnosis of this child. But if we see closely, the child was diagnosed as congenital hypothyroidism at 2 weeks of age. So 2 weeks of life, the child was born. At 2 weeks, she was diagnosed, appropriately diagnosed, and started on therapy. Now, someone or many of us, we think that kids, they do not suffer from hypothyroidism. This is an unknown thing in a child. But this is how cretins, or this is how congenital hypothyroidism leads to mental retardation. So these kids require thyroxine replacement. They will not be benefited by any other therapy except thyroxine replacement, because it's a medical emergency. It causes the medical emergency which requires thyroxine replacement. Otherwise, the child will land up as a troubled child, or the child will land up as a mentally retarded child. So that is very important. So the child was on thyroxine replacement, and a good dose of 50 microgram per kilo was started. Now this thyroxine was started, but what happened is the child was normal on treatment, and that's why parents thought that such a small child will not have thyroid disorder. Unnecessary, we are giving tablet to the child, and they stopped treatment. And once the treatment was stopped, in due course of time, within 3 to 4 months, the child landed with this condition. This was the clinical. So constipation, excessive sleepiness, and all these things were there in this child. So thyroxine was restarted, and compliance was stressed. They were told that the child, now we can see the previous picture and this picture. The child looks alert, she is developing normally, and compliance was stressed and ensured. So what is the important take home message from this? That kids do have thyroid disorder, that is very important. Diagnosis and treatment of congenital hypothyroidism is to be started at the earliest, because it causes developmental delay or neurocognitive delay, and for a normal neurological outcome, we have to start therapy. A good dose of 10 to 15 microgram per kg per day is to be started. And the most important thing which was not done in this child was stressing the compliance. So we have to tell them that the child is looking normal because of the treatment. The child will remain normal only when you continue therapy. Once you stop the therapy, the child may deteriorate. So this is a very important thing we have to explain to them. So this was an important take home from this case. Now coming to this child. This was a 4-year-old male child, came with excessive weight gain and poor growth. So this child has started graining, and if we take or look at the picture closely, there are purple stria, the moon face, typical Cushing's-like face. And when I took the history, the child was taking steroid drops, the betnesol drops were prescribed. They were rightly prescribed to the child when the child was having upper respiratory tract infection, but they were told to stop the therapy. They didn't stop the therapy. They continued it, and once they continued with it, the child developed the Cushing's feature. So this is exogenous Cushing's and was admitted with hypotension. Once a person saw this, the child, they were told to stop the betnesol drops. They were told to stop the steroid intake, and the child immediately, within a week or 10 days, got admitted with the hypotension, hypoglycemia, and lethargy. Now, why this happened to the child? First, all this picture, all this picture is because of exogenous steroids. This child was started on steroids and started gaining weight. Growth was stopped, and later on, the steroid was stopped abruptly. After getting a prolonged treatment with steroid, they should not be stopped abruptly because of the suppression of the adrenal gland. So on examination, the height was only 84 centimeter, weight was 23 kilos, and we can see all the stigmas of pushing. The investigation, morning 8 a.m. cortisol. So important to remember in this lab test is we do cortisol in the morning because of circadian rhythm. It has to be done 8 a.m. in the morning. If we are suspecting endogenous Cushing, then they are to be done in the night also to check out whether whether they get suppressed in the night or not, because the first thing to be lost is the normal circadian rhythm of the steroid secretion once a person develops Cushing. That is endogenous. But here it was clear, history was very clear in the that's why I did only a 8 a.m. cortisol, and this was a case of iatrogenic Cushing's. Now, what is the take-home message in this child is steroids are to be used very cautiously. They are like double-edged sword, and one should know how to use it. They are, you can see, take it from the first case that steroid was the drug of choice. And there are many conditions in which steroids are given, including nephrotic syndrome, including all other involving autoimmune disorder, involving other systems, and including vitiligo and all. They have we have got inhaled steroids, we have got oral steroids, we have got local application of steroids. So they should be used cautiously and used when absolutely necessary. I'm not saying don't use steroids, but important is when it is absolutely necessary, and the use the least possible dose. I mean, which is causing, don't give extra steroids to be on the safer side. And local steroids are better than systemic use of steroids. If the person is responding to systemic steroids only, then it has to be used. Otherwise, local steroids are better, and they should be shifted to steroid sparing agents. So steroid sparing agent should be started as soon as possible when we know that the child or the person requires steroid for a longer time. The most important thing is never stop steroid abruptly. Okay, this child landed into ICU because the steroid was stopped abruptly in this child. So never do this because adrenal recovery may take perhaps more than a year or two sometimes. So this child came and was started on steroid because the adrenal gland were suppressed and the child was not producing cortisol of himself, and he requires 2 years. After 2 years of continuous follow, this is how the child was started looking. But this is after 2 years. The child started growing, all the fat and everything subsided, and the child.
You're presenting.
Yes, sir. Hello. So yes,
You continue, sir.
yeah. So we can see the child has completely transformed into a normal child, but it requires 1.5 to 2 years, and this child required almost 1.5 to 2 years of steroid replacement therapy. We kept on checking the morning 8 a.m. cortisol, and when it was adequate, then only we were able to withdraw the exogenous steroids. Coming to this child, this was a 9-year-old female child, came with short stature. This child was shortest in class and was diagnosed as Turner syndrome. So they came with diagnosis only. They already had a diagnosis of 45XO. As we know, Turner syndrome is a genetic or is a chromosomal disorder, and there is partial or complete loss of X chromosome. And this was a mosaic Turner. So they have class. The most common symptoms are short stature, absent puberty, and later on infertility. These are the most common endocrine problems which we face. They also have more prone for heart diseases, ear abnormalities, hearing defects, intellectual disability. All these things are non-endocrine. But if we see endocrine point of view, short stature and absent puberty, later infertility are important. So the child was actually counseled that this is a genetic disorder and nothing much can be done to the child, and this child would perhaps remain infertile and perhaps will not marry. So this is how the counseling was done in this child, and the parents were shattered, and they didn't go anywhere because of this counseling. That okay, it's a genetic disorder, absolutely correct, and the short stature is very common in these kids. Yes, they do not enter puberty. I completely agree. They sometimes do not enter into puberty by themselves, and they require assistance. But the counseling of or the telling the child that nothing can be done for this child, telling the parents that is very that was a heartbreaking thing for the parents. Now we can give for short stature, growth hormone is a recommended therapy. So if we look at the growth chart, this is how the child was growing on a normal growth chart. But if we see the growth chart of a Turner child, when we started growth hormone, we can see the child has started climbing up in his percentile. So the normal growth velocity, which is low in Turners, becomes normal. That's why it should not be compared with the normal chart. It has to be checked on Turner's growth chart. And what for puberty, we require estrogen replacement therapy for induction of puberty as well as maintenance. So these developed breasts also get development of the uterine cavity. A healthy uterus is formed, and they have regular menses of withdrawal bleeding. Once we add progesterone to this child, then progesterone to such females, then they develop proper regular menses. Now, IVF with oocyte donor is also an answer to infertility. So they can very well get married, have kids with a oocyte donor. So what is important take home in this case? What I could tell you is we have to be aware of the newer therapy options. We cannot have the age-old thing of counseling. We should know what is new or what is latest, what is innovative thing or what is happening around the world. We have to keep on updating our knowledge and aware of the newer therapy options, because science and technology, it is evolving very rapidly, and because of the smartphone and Wi-Fi and networks, we all have access to almost all the data around the world. So that is a very important thing one should take a message from. Now, this is a 5-year-old female child. Coming to next case, 5-year-old female child came with lethargy, easy fatigue. बहुत जल्दी थक जाती है. ज़्यादा देर खेल नहीं पाती. पहले बहुत खेलती थी. This is a very typical complaint of the parents. This child was turning black. Also, what parent have noticed कि ये प्याज बहुत खा रही है along with salt. Pickle extra अचार खा लेती है काफी. So extra table salt. Now, when you ask this history, when you see such kids who is turning black and getting easily fatigued, the natural thing which comes to us is the child was on examination, the genitalia were normal. The child was thin built and 102 centimeters, though pigmented, but this was the anthropometry. Cortisol was very low, and when we did an ACTH, like the previous child, like in the first child, So what has happened, why I am presenting this case is, this child was a case of primary adrenal failure. So this came very well within reach without suffering from any kind of endocrine emergency or adrenal crisis. But this child had a low sodium, and that's why there was salt craving. The child was eating a lot of pickle and salad. ACTH was high and the cortisol was low. And we know cortisol or steroid is a stress hormone. And if the child would have gone into any kind of stress of infection, trauma, or any other thing, the child would have collapsed or gone into crisis. Again, the treatment of choice is steroid replacement along with mineralocorticoid replacement. Here, not only the steroid will not help because the sodium, only steroid will not help because the sodium is low. We have to give mineralocorticoid. So, zona glomerulosa, and that is mineralocorticoid replacing, we have to give that replacement of zona glomerulosa as well as reticular, fasciculata. And the child which was getting treated now started gaining weight, became active, and so what is the take home message from this is why this child was always, since 3 4 months the mother had went from doctor to doctor. She had brought 4 or 5 files of doctor, and every time they were reassured. Multivitamins were written for the child, calcium, vitamin D, and people are saying, everyone counseled the child कि ठीक है अभी आलस कर रही होगी बहुत ये कर रही होगी, and these were the words of the parent that we were trying to explain कि this is not my child, but everyone counseled them कि ठीक है kids they do it, बच्चे ऐसा करते हैं कभी कभी, and they were always prescribed multivitamin. But this is what the important take home is: we should always listen to the mother, because if we're not getting a diagnosis, or if the mother remains unsatisfied with the therapy, we should start revising our diagnosis and start looking at it. Okay, because if it's a multivitamin deficiency and you replace with multivitamin, the child should improve. So if we have that thing in mind, then that should reflect in the clinical scenario also. Now, this was a 12-year-old female, came with complaints of pain in the lower limb, and she has started developing various deformity. She also had mood swings. On examination, there were no signs of rickets, but bilateral genuvirus. On investigation, they came with some investigation: calcium of 10.4, vitamin D adequate 42, alkaline phosphatase high. So usually you get alkaline phosphatase high when vitamin D was low. Here it is 42, not very low, almost adequate vitamin D, but she was treated as vitamin D deficiency. And after 6 months of continuous therapy, still the child had similar symptoms. And I have already told you we have to come to revise the diagnosis and see what we are treating or what we are looking at. So when the child came to me, she was having pain while walking. She had various deformity. Her calcium was 10.9. Ionic calcium was 1.3 millimole per liter. Phosphate was 1.1. So now this phosphate is low. Calcium is on the higher side definitely, but phosphate, if we see, 1.1 is very low for this child, and a very high alkaline phosphatase of 1200. Usually you don't get alkaline phosphate beyond 2 or 300. Even with mild deficiency of vitamin D, you get alkaline phosphatase of 400, 600. But 1200 alkaline phosphatase with adequate vitamin D is really unlikely. And why the PTH is 92? Looking at the PTH, it is 92 picogram per ml with a calcium of 10.9. This suggests that something from is coming out of the parathyroid gland. And when I did a lateral CT scan, we can see a mass here in the neck at the region of thyroid. So this is a parathyroid adenoma, and a sesamoid scan was done. A sesamoid nuclear scan was done, which suggested a isolated primary parathyroid adenoma. So that's why the parathyroid is not getting suppressed despite high calcium. And when we go back to our books, we know that hypercalcemia causes uh, uh, the uh, the psychiatric symptoms or the kidney stones they develop, and the child has got bone pain. So pain, groans, moans, and bones. So bones are involved. So the important is interpretation of the results, endocrine. So take home messages when we are talking about endocrine reports. The previous report done was only calcium and vitamin D levels. No one bothered to do a PTH or a phosphate in this child. So the important is whenever we are doing endocrine labs, don't do a half-hearted assessment. I request you all, do not go for a half-hearted just to save money of the patient, or patient will not be spending money because they ultimately get mistreated or ill-treated. Suppose you do for thyroxine or for thyroid disorder, you check free T4 and TSH simultaneously. Then only we'll be able to pick it up the subclinical varieties. Okay, otherwise we won't be losing it. Similarly, if we do calcium without PTH or if we do calcium without phosphate, we won't be able to understand what exactly is going on in this type. So interpretation of endocrine results are to be done in toto. They have to be done not half-hearted, but a full attempt is given, and all other tests are to be done along with it. They should be interpreted with simultaneously. You cannot have calcium done today, PTS done tomorrow. We have to do it simultaneously. So glucose, insulin done together, calcium, PTH done together, free T4 TSS done together. So this is how we come to a diagnosis. So that's a very important take-home message from this case. I'll not go through this case. This is a very lengthy case, and involves genetics also. So I'll not go through this. Went to a big journey from oncology department to orthopedic department to coming to me. And this child had again same investigations were not done properly, and that's why the diagnosis was missed. And this child turned out to be a case of autosomal recessive hypophosphatemic rickets. Now coming to this case, this was a 4-year-old girl child, came with breast development since last 6 months. The child also had vaginal discharge and again increased appetite, similar to the first case, and tallest in class. There were otherwise no neurological complaints and no other positive history. Now what can we deduce from this is the child is having estrogen in her body. The child is getting exposed to sex steroids. Now from where this sex steroid is coming? So breast stage 3 were there bilaterally, vaginal mucosa was pink, the height was not increased, the expected height was almost 100 centimeter, this is 109, and weight was 16 kilos. Bone age was advanced, and if we see the LH, particularly the stimulated luteinizing hormone, is 7.2, which clearly suggests that the pituitary gland has started working. This child has a working pituitary gland. Usually what happens is during the pre-pubertal age group up to 9 years or 10 years of age, the pituitary gland does not secrete any gonadotropins. So what happens with the onset of puberty? We have got hypothalamic GnRH, which is a hormone under the influence of which this pituitary gonadotrope starts secreting gonadotropins, that is LH and FSH. Under the influence of this LH and FSH, the gonads, like testes in males and ovaries in females, they start maturing and they start secreting sex steroids. So once the sex steroids are there, then male secretes testosterone, or testicle secrete testosterone, and in females estrogen is secreted, and they bring about the secondary sexual characteristics. So here we have secondary sexual characteristics as well as gonadotropin levels, which is high. The uterus dimension was increased, and I did an MRI just to rule out any pathology in the pituitary gland, which was normal. So this child came out to be idiopathic central precocious puberty as a diagnosis. So this child should be treated. Why this treatment is required? So again, we are talking about the treatment benefits. We should assess because it's a natural process. Again, someone would say that going into puberty is a natural process. But most important thing is once a child enters puberty and attains menses or menarche, we know the height potential becomes limited, and the height gain which is expected, they usually remain short. So there is loss of height potential. Along with that, just imagine how what the psychological or psychosocial outcome of this child when is only 6 year old. So in third standard or fourth standard, they start menses, start bleeding. So menses starting very early in second standard or fourth standard, it's very early for any child, and they suffer from the psychological issues. How do we treat? We treat them with GnRH analog depot. There are multiple injections, and what these do is they cause regression of the sexual characteristics, slow in the height gain, and that's slowing in the bone age advancements. The bone age does not progress, and they come closer to the chronological age with therapy, and this causes increase in the height. And coming to this child, this was again an 11-year-old female sent for surgery from outside Nagpur. They were sent to Nagpur for a large abdominal mass on USG. Someone did a USG because the child had got such a big tummy and was sent for surgery at Nagpur. She was having evaluation of hematuria and labeled as intermittent spotting and irregular menses. But we can see that the child is not growing well. Okay, the child has not grown. Now, usually, what we see is whenever you have seen a child having menses, before menarche, the height spurt usually happens in a girl child. So the pubertal growth spurt, एकदम से तेजी से height बढ़ती है, and then they have menses. So that's a very important thing to know, that they grow and then they develop menses. Here, they were having irregular menses, but the child was not growing well. The height was 122. There were incongruent pubertal signs, and per abdomen there was a huge mass palpable. The bone age, usually which get advanced with puberty, was delayed in this child, and the CT scan was done, which shows this big ovarian cyst. So we can see on both the side 8 by 10 ovarian cyst, and someone thought that this ovary is secreting estrogen, and that's why the child is having intermittent spotting. But when we check the thyroxine, TSH was more than 500 and free T4 was very low. So again, this was a prolonged untreated hypothyroidism which is presented with precocious puberty. I told them not to do surgery and started them on thyroxine replacement. This thyroxine replacement has stopped the menses and child has started growing well. The ovarian cysts, which were huge, will respond or will regress with time. Coming to another case, this was a 2-year-old male child, similar issues with puberty. We can see height of 102 centimeter, which is expected in a 4.5-year-old male child. And here, the bone age also was advanced to 10 and a half years. The child was muscular. And these were the genitalia. We can see pubic hair, they were shaven. There's large testicle, bilaterally almost volume of 8 ml, and a good grown genitalia. So it does not look or coincide with the genitalia of a 2-year-old. The testosterone are high, the LH was pubertal, and when we did a stimulation test, that also had a pubertal response. The MRI was normal in this child. So this was a central precocious puberty without CNS involvement in a male. The again was started on GnRH analog because again the same reason, the child will have the height potential will be lost if that enters puberty. So that was a female case of female with precocious puberty. This is a male child with precocious puberty. Now, this is a very interesting case, and this is a 4-year-old male came with genital development, aggressive behavior, and increased appetite. He was tall and have visual complaints. They did an MRI which showed a space occupying lesion, but pubic hair, we can see the genital stage is also on the has progressed. So this is only 4-year-old child, which is clearly abnormal in this child. The child is also tall and had neurological dysfunction and in the form of visual field defect. The LH was detectable in this child, bone age was advanced. But and he was right, he was started on GnRH analog therapy, but was not improving, worsening of symptom. So again, when you get a patient who is not following the expected response, one should try to revise the diagnosis, whether we are not whether we are correctly diagnosed the child or whether we are treating it properly. I did a stimulation test which showed only slightest rise in LH levels, and testosterone was very, very high. So MRI again had space occupying lesion, and hypothalamic hamartoma becomes unlikely because they do not usually grow. HCG levels in this child were high, and the child went in for neurosurgery opinion. They went to 2 or 3 places for neurosurgery opinion. Every time they were told that okay, we get the surgery done and remove the tumor. But I told them that we wait and check with an oncologist first because this was suspected to have a extragonadal germ cell tumor, that is a CNS germ cell tumor. And the oncologist, we have a pediatric oncologist with us at Nagpur. The reports were also sent to Mumbai, and finally, they were suggested that the child requires chemotherapy. What is the treatment of choice for such kids is shrink the tumor size by giving chemotherapy. Once the tumor is shrunk, remove it through surgery, and then do radiotherapy. Otherwise, the child, if first surgery is done without chemotherapy, then there is a chance, high chances of residual disease to be there. So it is very important that we should check what went wrong in this child. Is the HCG levels which were high, it was not done anywhere. When it was done, still with a high HCG levels, he went to all the surgeons and everywhere, but could not be picked up as germ cell tumor. So important is once the child comes with all the reports, we must see all the reports brought by the patient. The patient might be roaming around since 4, 5 months, 6 months with 7, 8 files, and we should respect those workups which has already been done, and the time which has elapsed. The child probably might be having very less time left, and we should be seeing all the files, all the investigation brought by the patient. This is again a precocious puberty, 14 month in a 14-month female. Very early we can see the breast development, but here the precocious puberty is premature thelarch, which is an isolated condition, and say they may regress with time. But very important to do a workup before telling them that it's a normal and will disappear. Do not massage or put any oil or try to remove the milk of the child, because many times we have seen the dyes and all, they actually pinch the nipples and take the milk out and say that it is witch's milk and has to be removed. Otherwise, the child is suffering, will suffer from this condition. So they may progress to central precocious puberty, and a close clinical follow-up is required. This is a very interesting case. This child has been there since last 10 years with me. So this, when he came, he was 6-year-old, came with tetany, and was diagnosed as having hypoparathyroidism, adequately started on vitamin D replacement. This was a child born of consanguineous marriage and was well-grown child, adequately nourished, height was 115 centimeters. Only thing he had nail candidiasis. Otherwise, there were no positive signs seen in this child. Calcium was low, phosphate was very high. We can see phosphate of 11. And with low calcium, we do PTH. PTH should be high if the calcium is low. But here the PTH is very low, and the child was diagnosed as having hypoparathyroidism and was started on calcium and calcitriol replacement therapy. Subsequently, the child was growing well, developed nephrotic syndrome, recovered, everything was going fine. Till one time he came with lethargy, dull, and poor effort tolerance, and the child was hyperpigmented. So now what is happening here is the sodium, when I checked, sodium was low, potassium high, and cortisol again, the steroid levels were very low, along with a very high ACTH, and that's why the hyperpigmentation. The child was subsequently diagnosed as having primary adrenal insufficiency and started on steroid replacement therapy. Now the child started growing and everything was fine. Again, nephrotic syndrome came and went. The child was on calcium, calcitriol, hydrocortisone and fluorocortisone. This is how the child was over a period of years was growing. But now at 12 years, he has come with palpitation, weakness, and generalized unwell. He has lost 1 kilo, and the growth failure we can was evident in this child. The heart rate was 112, so the child had tachycardia. So free T4 was high, TSH was highly suppressed. A technetium scan was done, which was showing poor uptake or suggesting thyroiditis. So not typical of Graves, but the biochemical picture looks like Graves disease. The clinical picture looks like Graves disease. but the scan was able to differentiate between Graves and thyroiditis, and TRAB antibodies they were done, it was negative. TPO antibodies were positive. So anti-TPO antibodies they point towards developing hypothyroidism, but before this hypothyroidism developed, this child they kids develop hyperthyroidism. The preformed thyroid gland it gets secreted. So I this child was started on beta blockers and HbA1c was also checked was 5.9. So child calcium, calcitriol for hypoparathyroidism, for adrenal insufficiency, he was receiving hydrocortisone and fluorocortisone, and for his hyperthyroid symptoms. So we can now see that the child is having multiple endocrine problems. So I did a genetic workup in this child, and which was positive for AIRE gene. So this was a case of autoimmune polyendocrinopathy syndrome, which is autosomal recessive, and that's why it was seen in this consanguineous couples kid. So this the marriage was consanguineous, and uh, this was a homozygous condition leading to autoimmune polyendocrinopathy. And when we see the APS, it has got chronic mucocutaneous candidiasis as one of the features. It affects nails, dermis, and we could see the nails had that fungal infection. And the onset is usually 2 to 3 years. They have the second most common is hypoparathyroidism, which this child had, and autoimmune Addison's disease. So when we get all this classical triad and multiple endocrine involvement, we should check for this gene. These are all the likely endocrinopathies the child was expected to have is diabetes mellitus, type 1, autoimmune thyroid disease, autoimmune hypophysitis, and hypergonadotrophic hypogonadism. The testicle might get involved later in time. They also are more prone for autoimmune skin disease like vitiligo and alopecia. With this, we have got immunologic defects, we have ectodermal dystrophy, keratoconjunctivitis, and various gastrointestinal diseases. So at 13 years, 6 months, this is the present status. The child is growing well. He is on thyroxine replacement for hypothyroidism, calcium replacement for or calcitriol replacement for hypoparathyroidism, hydrocortisone and fluorocortisone for adrenal replacement, and started on insulin because the HbA1c was high and the child was started on basal bolus. So there were all 4 to 5 endocrine organs getting involved in this child. These are very. I'll go through these cases quickly. I'm running out of time. So these were 2 cases who came with clitoral hypertrophy, and this is clearly a female child with clitoral enlargement. And both the cases, one is a 4-year-old child, one is a 6-year-old child, and both became with clitoral hypertrophy. One was gradually increasing the first one, but the second one was developed over 5 to 6 months of age. When I did the workup, 17 OHP was higher in this child and DHEAS was low. Again, there are very specific endocrine tests are to be done to come to a conclusion that like ACTH stimulation test, a very specific endocrine test, and this child was having simple virilizing variety of congenital adrenal hyperplasia. Again, the same enzyme defect in the adrenal gland started secreting testosterone, which should not come in a female child, and because of this testosterone the clitoral size started increasing. Similarly, in the other child, DHEAS was very high. A CT abdomen was done, which was suggested an adrenal tumor. So this adrenal tumor was secreting a lot of androgen, weak androgen, though DHEAS is a weak androgen, but a very high level leads to virilization or clitoromegaly. So this child had adrenal tumor. So with this, I would like to say thank you all for your giving me time and your patient listening, and I would be happy to uh, answer any questions if there are. I'll stop sharing my screen and come back to you. I hope you enjoyed the presentation and I did justice to your time. I over to you, sir, if there are anything.
Thank you very much, sir, for such a beautiful and informative lecture. This has definitely added to our knowledge. And now I request our esteemed chairperson, Dr. Kodwani, sir, to propose the chairperson's remark. Sir, kindly unmute yourself.
हाँ हो डॉक्टर, थैंक यू डॉक्टर मंगतानी। आपने एम आई ऑडिबल?
Yes, sir.
सर यू आर
Yes, sir.
ऑडिबल।
Very much.
सर आपने आपने जो हमें जानकारी दी, बहुत इंटरेस्टिंग जानकारी दी। आपने हमें ऐसी लगा कि आप हमें ओपीडी में लेके गए और क्लिनिकल डेमोन्स्ट्रेशन चल रहा है। इस तरह से आपका प्रेजेंटेशन था, बहुत अच्छा लगा। क्योंकि कई बार ऐसा होता है कि वेबिनार में पूरा थियोरेटिकल नॉलेज हमें मिलते रहता है, बट एक्चुअली बहुत इंटरेस्टिंग क्लिनिकल नॉलेज हमें मिला। अभी अभी सर आवाज आ रही सर?
हाँ जी
सर
जी।
सर
तो
हम
ये
लोग
ओबीसी केसेस जो आप बता
ना डिटेल में तो हमारे ब्रांच में उसका उसका उल्लेख नहीं है, उतना डिटेल एक्सप्लेनेशन नहीं है। तो ये रूटीन में अगर हमारे पास आते हैं गलती से भी, तो हमें एक अच्छा नॉलेज मिला है कि हमें उसके को किस फॉरवर्ड करना चाहिए। इस वे से आपने बहुत अच्छा नॉलेज हमको दिया है। हमारे स्टूडेंट भी हमारे साथ बैठे हुए हैं, और जो हम लोग ओपीडी में काम करेंगे या बाहर जो लोग ओपीडी में पेशेंट्स देखते हैं, उसके लिए बहुत बेनिफिशियल नॉलेज आज आपने दिया है, और ये हमें बहुत अच्छा लगा है। आयुर्वेद में पेडियाट्रिक्स का नॉलेज है, बट सेपरेट ब्रांच जैसे एंडोक्रिनोलॉजी इन आयुर्वेदा ऐसी कोई ब्रांच हमारे पास नहीं है। उस वे से हमने जो आज देखने को मिला या सुनने को मिला, ये बहुत अच्छा लगा। थैंक यू वेरी मच।
सर, मैं वही कहना चाहूंगा कि जब हम अडल्ट एंडोक्राइन प्रैक्टिस देखते हैं तो उसमें बहुत सारा चंक एक डायबिटीज की तरफ चला जाता है। टाइप 2 डायबिटीज जिसमें आपका इंसुलिन रेजिस्टेंस से लेके दूसरा सब कुछ रहता है, एंड बहुत सारा थायराइड डिसऑर्डर पे अटक जाता है। ऐसे चुने हुए केसेस थोड़े से रेयर हो जाते हैं, और आपको भी जो लेक्चर्स आप अटेंड करते होंगे या वेबिनार अटेंड करते होंगे, ये सारे वेबिनार और ये लेक्चर या तो डायबिटीज के बारे में होंगे, टाइप 2 डायबिटीज के बारे में होंगे, या फिर थायराइड डिसऑर्डर्स, प्रेगनेंसी में क्या होता है थायराइड डिसऑर्डर। बट जब हम पीडियाट्रिक की बात करते हैं, तो जब पीडियाट्रिक एंडोक्राइन, ये एक बहुत बड़ा टॉपिक है। इसमें तो मैंने अभी एड्रिनल और सिर्फ सेक्स हार्मोन्स और बोन्स के बारे में बात की है, जब या थायराइड के बारे में बात की है, शॉर्ट स्टेचर। बट जब हम देखते हैं तो बच्चे जो अभी मोटे हो रहे हैं, टाइप 2 डायबिटीज हो रहा है बच्चों में, या टाइप 1 डायबिटीज जो इंसुलिन डिपेंडेंट डायबिटीज है, वो मेरा एक्सपर्टीज है। देन वी सी ओबेसिटी, शॉर्ट स्टेचर, बहुत सारे बच्चे जो शॉर्ट हैं, या इरेगुलर मेंसेस है, डीलेड मेंसेस के केसेस मैंने नहीं डाले बिकॉज टाइम हमारे पास इतना ही था, तो हमने आगे के केसेस वो कर दिए। यानी मेरे पास एक लिस्ट है 50-60 केसेस की, जो कि एक प्रेजेंटेबल होता है, बट वो उसके लिए 2-2.5 घंटे का डिस्कशन लगता है। बट थैंक यू वेरी मच, आपने अपना समय दिया, एंड आई
नहीं
होप
सर,
यू एंजॉयड।
थैंक यू आपको सर। इतना फाइन और क्रिटिकल डायग्नोसिस बहुत इजी नहीं रहता। हमें भी एक डायरेक्शन मिला कि डायग्नोसिस करने के लिए किस वे तक जाना चाहिए। बहुत अच्छा लगा, थैंक यू सर।
तो मेरा बस एक आखिरी टेक होम रहेगा कि पहले तो हमें पेरेंट्स का एग्जामिनेशन हिस्ट्री प्रॉपरली लेना चाहिए और लोकेट करना चाहिए कि प्रॉब्लम कहाँ है। फिर एंडोक्राइन टेस्ट करते समय कंजूसी नहीं करनी है, जो इम्पोर्टेंट टेस्ट है वो एक साथ करने चाहिए, बिकॉज उसको एक साथ अगर हम चेक करते हैं देन ओनली वी गेट अ डायग्नोसिस। और एक बार अगर हम डायग्नोसिस नहीं कर पाए और हमने थेराप्यूटिक्स पे जंप किया, तो हमारा अगर एक्सपेक्टेड रिस्पॉन्स नहीं आता है, तो देन वी शुड रिवाइज, ट्राई टू रिवाइज द डायग्नोसिस एंड कम टू कंक्लूजन। अगर पेशेंट बहुत घूम फिर के बहुत सारी फाइलें लेकर आ रहा है, तो इम्पोर्टेंट है कि थोड़ा सा ओपीडी को रोक के समय देके उसकी सारी फाइलें पढ़ी जाए, क्योंकि बहुत बार डायग्नोसिस ही मिस हो जाता है। ट्रीटमेंट के लिए सब लोग रेडी हैं, बट डायग्नोसिस ही मिस हो जाता है। तो दैट इज व्हाट आई कुड रिक्वेस्ट। थैंक यू सर, थैंक यू सो मच फ्रॉम माय साइड।
थैंक यू।
Thank you very much, sir. You have, it's very true whatever you have said. And when some 4-5 years back, I heard the sir at in one CME at Nagpur, and that time only I thought about inviting sir on our platform, and it is a wonderful opportunity. That lecture was so mesmerizing. Then and then only I thought that sometimes I will call the sir, but where to call? Then in 2016, we constituted the RVPG organization, and there is no other best dais than this to call the sir to let our people know about the intricacies of endocrinology and the very sharp process involved in the process involved in making the diagnosis of endocrinal disorders. Now, just we had witnessed how critical the process is. Right from it may turn out to be some gland hyperplasia or dysplasia to the tumor also. So with this, I will now request Dr. Shama Karikar madam to put the vote of thanks before final
Sir, am I
conclusion.
audible, sir?
Yes, you are audible.
Okay. Namaste. Myself, Dr. Shaba Karikar Bhoi. I am Associate Professor and HOD of Parul Institute of Ayurveda, Vadodara, Gujarat. Don't worry, I won't take much of time. I'm here to convey the formal thanks to all the speakers, chairperson, and organizing committee. So on behalf of RVPGA organizing committee, I extend my heartfelt gratitude to Dr. Hari Mangtani sir for sharing his expertise on endocrinal disorders, clinical laboratory diagnosis and treatment with, I think, 15 plus case presentation are there. Thank you for enlightening on this concept, sir. I think the way of presentation of the sir, incorporating the real life cases and explaining the theoretical knowledge with that approach is very much beneficial, indeed beneficial to all the PG scholars, all the Ayurveda faculties who are joined here. So, sir, thank you very much. Also like to thank our chairperson, Dr. Ghansham Kodwani sir. I think the exchange of knowledge is very much better experience with the addition of Ghansham sir. Thank you. Also the thanks to the organizing committee members with whom this event would be possible. So special thanks to Dr. Subhash Wage sir, President RVPGA, Dr. Santosh Chavan sir, Dr. Avinash Radke sir, Dr. Vaishali Ganorkar madam, coordinator for this webinar, Dr. Pallavi Chaugule madam. Without, I think, their active work and contributing, this seminar would be a resounding success. So let us carry forward this exchange of knowledge, continue our commitment to advancement of pathology, etc. So thank you once again, Dr. Mangtani sir, Dr. Kodwani sir, all the organizing members of this Maidan in February 2024. Thank you so much.
Thank you, Kshama madam. And before I say final conclusion, I would like to express my deepest gratitude to Hari Mangtani sir, because after so long gap, when I contacted him at a single request, he accepted our invitation and enlightened us with his wonderful lecture on endocrinology. So thank you once again, Hari Mangtani sir. We are really blessed, and thank you once again. Now I declare this meeting is over, and now people can leave.
Thank you, sir.